Thanks for having me today. So I'm Shola Adeleke. I'm an oncologist. I'm based in London. I'm also the CEO of Qnetics with cancer. So I'm going to be talking about some of the products we're developing in our company. We're a cancer medtech company, and one of the things we do is we develop proprietary models which is able to predict response to treatment. So we're focusing on immunotherapy at the moment. Just give me a sec. Yes. So one of the things we do, like I was saying, is that immunotherapy came on board about 10, 15 years ago, and it's literally transformed the way we manage some cancers. Melanoma used to be a death sentence. People had dacarbazine and interleukin, and they're sick very poorly, and they don't still respond to treatment. And I think 10, 12 years ago, that's when the first IO checkpoint inhibitor came on board, and it's changed the way we manage these patients with cancer. Next slide.
You can push the green.
Yeah, okay, thanks. So compared to chemotherapy, immunotherapy works in a slightly different way. Many of us know this in the audience. It unleashes the body's immune system against cancer. When the cancer grows in the body, the cancer has a way of shielding itself from the T cells, which kills all the cancer. So this takes away the break off the T cells so that they can, identify the cancer and kill them off. And if patients do respond, they respond really well. So we're talking about, very good response, durable response in a small percentage of patients. Some people respond, with lung cancer, 2-3 years. We're not even talking about cure, in parentheses in some patients. But for the majority, they do not respond to treatment. So we're talking about the response rate, depending on the cancer type, is about 20 to 30% of patients who respond. The majority of patients that do not respond, they're also burdened by the side effect from this treatment, the toxicity from this treatment. So just to give them some data, some information about the burden of cancer. We've been talking about cancer today for most of the sessions. So as of 2022, the number of new cases of cancer was about 20 million, and the number is expected to rise to more than 40% by 2040. So the incidence of cancer is rising, the prevalence of cancer is also rising. And we do know that majority of those patients that we diagnose or we manage for cancer now will be eligible for immunotherapy at some time point. And if you look at the cost of giving immunotherapy, so these are US data set or US data. So in the US, it costs about upwards of $100,000 per patient per year to give immunotherapy. And in the UK, depending on your bargaining power with a pharma company, it could be between 70 to 80,000 pounds per year to give immunotherapy in patients. And despite that, over half will still have some immune-related adverse events, which could be as bad as a rash. It could be as severe as you go into intensive care for colitis, pneumonitis, hepatitis, and all of those itis, which could be quite a burden on the healthcare system in terms of the costs. And having done all of that as well, only about 20% or 30% of patients will respond to treatment. So you have a paradigm where you have a very expensive drug, which doesn't work in everybody or majority of patients. It also makes people very sick and puts a burden on the ANA systems or healthcare systems in the front door, even in the back end of the hospital as well. And the way we select patients now for immunotherapy, we use a biomarker. It's a protein biomarker expressed on a cancer cell. It's called PD-L1. There are a few other ways you can analyze it. You can use TPS, you can use CPS or TMB, and all of those protein-based biomarkers. But the problem is that it's a very lousy biomarker. It doesn't select patients very well. So if you have a situation where you select a patient, you give them treatment, they don't usually respond. If they do respond, only about a small percentage of them, about a fifth of patients to respond. And you also have a situation where you have to deal with the consequences of a treatment when they are not even responding. So we've done some analysis in-house where we know that the 56% of patients here that did not respond to that did not receive immunotherapy because they've been excluded or been screened out could actually benefit from immunotherapy. And we're missing the opportunity here where some people could have their disease controlled. Some of these people end up with chemotherapy or other types of targeted therapy, which is fine. But if they are going to be a good candidate for treatment, we shouldn't be missing them out in the whole pathway. So what we've done as a team in my group is that we found a way to leverage the existing information about the patient So when a patient comes in through the door, you've got a diagnosis, you have a baseline scan before you go on your treatment. You have a maybe lung cancer CT scan or PET scan or the other MRI for the cancer types. And we also have information about the genomic profile. So some cancers now we do limited genomic profiling, depending on the trust or the hospital or the country. You might even have expanded panel. And we also do have clinical data about the patient. So things about your past medical history, your history of cancer in the family, whether you've got a germline mutation in your family, for instance, or whether you've got other comorbidities, or for instance, on antibiotics or you're on steroids. All of this information could interact or could affect or impact how you respond to certain therapies. So we built a system which is able to ingest all of this information, this multimodal data, is able to look at a genomic profiling, which is already existing. It looks at the imaging, so the CT scan, your MRI scan, your even scanned high resolution pathology slides from the pathology lab, and also your information from EHR or EMR systems. We're able to find unique characteristics across all of this information, which is unique to the patient. You can use that to now personalize a treatment for that patient, whether they're going to respond to immunotherapy or not. And if you remember from one of the numbers I've given you earlier on, about 20% of patients will respond. So from the analysis we've done, we're now getting over 80% accuracy from the retrospective analysis we've done on patients in the UK. We're also doing some analysis in the US as well. And we're expanding out some of the work in Paris and also in Marseille in France. So all of this analysis can be done within a few hours, within a day. One of the good things about this is that you don't need to collect a new tissue sample or collect a new blood sample. Existing information, which we do have access to in the clinical space, is what we can still use to protect or to predict who is going to respond to therapy or not. So this is a typical, I just given this typical pathway, if you like. So maybe a 6-year-old man or some ex-smoker or even a non-smoker in some patient population with lung cancer, they don't have to be a smoker. Some certain quarter patients do also have lung cancer. They come out with a cough to the GP or weight loss, or they have some blood in the sputum, hemoptysis, and they go have a chest x-ray. They go to secondary care with a chest x-ray. They have a myriad of investigations. They go through the system, have a CT guided biopsy or EBOS or PET scan. All of this information has to be reviewed by the tumor board, or we call it MDC in the UK. And they will now make decisions on the kind of care based on the staging of the patient or the fitness of the patient, and also the type of cancer they have or subtype of cancer they have. And there are two touch points we think we can make an impact. The first touch point is when you're doing the diagnosis itself, even though that's not a valid proposition, but we found that we can actually also make better accurate diagnosis for lung cancer or even other cancer types by looking at just a blood sample alone. I know other companies are looking into this, so that's not our key value prop yet. The key is that when it comes to we're not just doing lung cancer, by the way, we're doing other cancer types. So we're doing breast cancer, urological cancers as well. When it comes to when to maybe give IO or chemo-IO combination or other types of treatment for that matter, PD-L1 could play a role. But we do know that it takes a few days to get the results back. In the UK, it takes about 3 to 10 days. It could be faster in some trust. In some low resource setting, it might take longer. And when you even get the result, it's not even accurate. So we're saying that we can actually change or impact the pathway positively by being more accurate, by selecting the right patient for the right treatment, and also making sure that the clinicians and the patient work together in terms of the joined up care when it comes to making decisions about the treatment. So this is just the workflow, if you like. So the local input is very basic. Imaging, genomic, clinical. We patented this technology, by the way. We tested in about 3,000 patients. We just set in about prospective study to get this validated. So if anybody's interested, you can come and speak to me afterwards, and we can get results out, like I said, within hours or within a day or two. So just to give you the impact in terms of the, we're talking about commercialization of technologies here. So globally, we know there are about 20 million patients who will be eligible for some type of biomarker testing for immunotherapy. And the market value for that is about $20 billion. In the EU, we have about 5 million people or patients who might be eligible for immunotherapy testing as well using a biomarker. And if you combine the market for the EU as well as the UK and North American market, it's a good chunk of patients. And if you look at the key patient population here, when it comes to high incidence cancers like lung, melanoma, breast, and all of those things, they have a good chunk of patients who might be eligible or might be benefited from this kind of technology. So these are some of the partners we're working with in the UK, in the US, as well as in some centers in Paris, in Marseille as well. This is some of my team. It's a diverse team. We have cancer biologists, we have radiation oncologists, we have data scientists, we have a professor of machine learning working with us. So it's we know it's a complex problem because for each of these data types, you need different skill sets. So for genomic data, you need bioinformatics. You have to be very good at that. For imaging, you need computer vision. So you need, deep learning, CNN, DNN, and all of those other types of deep learning tools. For clinical data, usually they're unstructured data. They're not very clean. You have to do a lot of processing on those data. We used to use NLP. We're now using generative models to be able to find some insight into those data. So it needs a lot of technical know-how and also domain knowledge in oncology or in medicine or in cancer before we can able to scratch the surface of this technology. And this is some of our NEDs. And so we hope this is just one of the things we do. But just to see how this interplays with some of the discussion we're having today in terms of technology and how it could impact how we think in terms of cancer control in Europe, in the UK, other parts of the world as well. And thank you for listening.
Thank you very much. I think this is extremely impressive work and important work that you're doing. I don't think we have much time for questions from the audience right now. But if I can sneak in one question, because I think what you're doing is really to decide what patients will benefit from immunotherapy, who will not.
Yeah.
And it's good for patients. It's probably also good for the hospital. But for a pharma company that sells per patient, that may be a challenge. How do you work with these forces?
Yeah, so very good question. So we also work with some pharma companies. I think some of the things they're worried about is about the number of sales or number of checkpoints that they do sell, which is quite a rational way of looking at it. But we also flip the coin, and when we're speaking to them, we say that if you do know that when you're selling these drugs, the majority of the patient you're going to be giving these drugs to is going to respond, would you rather have that? In fact, you have more patients on that treatment for longer, rather than they stopping after 6 months or 9 months because they progressed. So when we put that, that argument to them, they understand viewpoint. Some of them still think that it's about the game of numbers, but it's also looking at the long term. If you put people on long-term IO, and we're also predicting toxicity, by the way, that they are not going to have grade 2 or grade 3 tox, and they're also going to keep responding for 2, 3, 4, 5 years. Do they need to have IO for that duration? It's debatable, depends on the trial data you're looking at. But they also see some benefit in the way we've put it across to them in terms of the benefit for the whole ecosystem, not just the profit or the market value they're trying to capture.
Good argument. Okay, thank you very much. Asrar, please, scene is yours.
Thank you. So you can all hear me. So I'm Asrar Ahmad. I'm from Siemens Healthineers. I work in the Varian business division. And the Varian business division is focused purely on oncology and has been so for about 75 years. And for the last 5 years, we've been part of Siemens Healthineers. Okay, so just to build on the previous slides and the presentations, cancer, we all know this, but it's no harm in just to reiterate where we are and what's happening in the future in terms of the predictions. So 77% increase in the number of new cases by 2050. So that's going to be about 35 million new cases. Okay, but we also know, and we hear this a lot from various clinics and cancer networks we talk to, that they don't have the staffing resources to deal with the patients that we're going to have to manage going forward as well. But the WHO predict that to be a 10 million potential shortage of HCPs, clinical staff, to deal with the number of cancer patients we're going to have to manage going forward. And just on that one, 50% of the world's population lacks access to adequate healthcare. And when we look at this at a global level, So we as Varian operate globally across a number of countries, from the US, Canada, across numerous in Europe to the Far East, and Australia, New Zealand as well. We deliver technologies, hardware technologies for radiotherapy systems, the actual units that deliver the radiation therapy, but we also deliver a range of technology that basically enables that hardware to work optimally and more efficiently, minimizing doses to cancer, tumors, and so on. The other side of what we do, and this is where I focus a lot, is the technology, the actual software technology. And within our own portfolio, we integrate the technologies. We have numerous technologies. We integrate that to work optimally between the different systems that we have, but also to integrate it to other systems as well, to enable that data flow from A to B, whether it's within the same hospital or within other hospitals as well, utilizing technologies that we have now, like Fire-based APIs, but also integrate within the clinical workflows to ensure the technology integrates into that workflow. Automating where possible through technology to make workflows more efficient. And more recently, with our AI innovations division, we're now bringing in much more AI into that workflow as well, to automate some simple tasks as well. But more importantly, and not to lose sight of this, is to personalize the healthcare experience for that clinic, but also to personalize it for the patient groups as well. So when we look at our portfolio, quite a range of solutions that you see here, from oncology management systems to analytics. The one I'm going to focus on is patient engagement, the one you can see on the top left. And that is a solution that we have implemented in about 200 cancer clinics globally to date, and about 235,000 cancer patients have actually used this system. There are various work streams within this particular solution called Nuna. And this particular work stream is around remote symptom tracking, so monitoring patients when they're not in the clinic. And if we just go through that workflow at the top, we have a range of structured symptom questionnaires with algorithms that are in there. Patients will fill out those questionnaires depending on the treatment module they're on. If it's a breast cancer patient, they'll get a specific style of questionnaire. If it's a prostate cancer patient, they'll get a different questionnaire. Each of those questionnaires have got their own triaging rules and algorithms that we've built and engineered into that portfolio. And then based on what they input, patients can receive automated messages providing them some digital support as to what they should do next. This is not particularly AI, but that's the direction we want to go as we develop going forward when we talk about what's going to happen in the next 5 years and so on. Right now, that content is provided by clinics. Content is provided by clinical content provider companies as well. But that will help patients get a level of digital support on how they should alleviate a particular symptom that they're reporting through the questionnaires. But from the clinical side, which is what we see down here, that workflow comes through to the clinic, utilizing a triaging workflow, red, amber, green scenario. Basically, what that means for the clinic team members is they can utilize this workflow to determine which patients I need to focus on first, i.e. the red patients. And we do that utilizing scaling like CTCAE for most of our questionnaires for mild, moderate, severe, through to NRS and ESAS as well. Okay. So this example is from a clinic in London, Barking, Havering and Dagenham Healthcare Trust, so Romford or Queen's Hospital Romford, utilizing this particular workflow with that solution. Historically, they had about a 21-minute prep time with their patients for a follow-up consult. And that was, manual processes, dialing, redialing, leaving voicemails, not getting through to the patient, and so on. So on average, 21 minutes. Now, utilizing a remote monitoring digital workflow where the patient is also engaged with that app, they can now manage that same patient in a 7-minute workflow. So that's a huge saving per patient for one clinic in one hospital. They're actually working on turning that into a journal publication, hopefully later this year or early next year as well. what we found as an organization is by putting in that particular solution, it actually brought together the different departments within cancer. And they all very clearly say it, that we didn't even know who the head of each department was until we implemented this solution, because that required us to collaborate together, which is quite nice to hear. I'm going to play this video.
And also a very, very important thing for me with Nuna was that it was actually, I was surprised how big of a shock it was for my family. And a lot of times it was like you were trying to show a brave face to everybody so they wouldn't worry about you, because you didn't want to put more stress on them. So I could do that with Nuna. I could put my stress into Nuna and not my family. So that was good. So it was good to have something where I could just vent like my fears and my sort of things that I was going through. But if it was things that were just like at the back of your head, just like nagging, and then you were wondering like, okay, what is this? What is that? Then I could always ask that question. And when it came to my mind, or when it was like, if it was the night time and I couldn't sleep, I could just ask the question. And then I would know that, okay, tomorrow somebody's going to answer.
Okay, so that's Karita on the left. She is a cancer patient who was introduced to Nuna and now works for Siemens Healthineers, because she loved the app so much. When she got through her treatment, she said, I want to work for you guys. I want to make this product better and better and over the years to come. So she's one of our product managers within the business now. Laura on the right is from the marketing team. But that's only part of the whole video. It's a whole 4-minute video. But just to point out, the way we've developed this particular product, it's patient-centric. Okay, so keeping the patient at the center of the journey, which gives the patient more control. They feel like they're in more control. They also hopefully have less anxiety as well, because, as I said, what I showed before is just one work stream. There's other work streams in there about sharing content, sharing educational material, sharing videos as well. And that can really have an impact. We're actually doing a study with the St. Luke Clinic here in Belgium. And what they want to do is monitor how, with this particular product, adaptive therapy and radiotherapy, adaptive therapy and non-adaptive therapy, and seeing what the outcomes are for particular groups of patients, and then utilize the data, because it's structured data, utilize the data to actually then work out which groups of patients will have particular side effects versus not having those side effects. And they can use that to inform the patient about their treatment options in the future for new patients to come through. So I'm going to stop there, because I know we're hitting the time. And just a couple of statements. I won't read them out for you, but you can see that there. Okay, thank you.
Thank you very much.